So that was a lot of interesting information about, how do we go about, assessing our readiness to take an
Yes.
exam, what we call the safe zone. What's the safe zone? Safe zone appears to be, from our expert facilitator, 70%, and you want to use a predictive measure that's
Yes.
evidence-based, such as the NBME. These are the exam writers. So it's the most predictive quality. So that's the safe zone. If you're scoring, and now also real quick, is there amount of past practice exam scores that we should aim for before feeling comfortable? Because we can knock that 70% out the park on one try. And should that be the benchmark, or should we go for 2, 3?
I always say a minimum of 3. So 3 weeks out from your exam, we do the first one, the second one, the third one. And if we are first in the mid 60s in terms of equated percent correct, and then we eventually surpass that 65%, we're going to be in very good shape. So if a scholar, for example, scores 62% of the first one, great, we're in the zone, because remember, it's 60 to 65%, but we're kind of on the lower end. So that second one, can we hit 65%? That's fantastic. The third one, if we can hit preferably 70%, that gives you that 99% probability of passing step 1. Right. But let's say you're at 67 or 68%, depending on the comparison group for that year of the NBME, it may say you have an 86% probability of passing. So if you're in that upward trend, then in consultation with preferably your medical education learning specialist, you are in strong position to do well on the step 1 exam.
So, and we don't want to overwhelm our student doctors, because this is a very intricate conversation.
Yes.
It's a lot to consider. When all of us, we just want to pass, we want to pass step 1, pass step 2, pass step 3, and live our best doctor lives, and so, but having all of these things to consider, it is a very nuanced conversation. And so with that being said, this brings us to the close, and we got a little bit more for you. But DT, just because we covered a lot in this first episode, can you give me 5 most high yield questions that a medical student would have going into their dedicated period? From your experience in the years that you've been advising, been dean, on admissions committee, what are the top 5 questions that you've encountered with medical students going into their dedicated period?
First one is, which question bank should I use? We've answered that. It's based on your learning preference. It's not the question bank, but what you do with it. So question banks, commercial question banks, help us practice our thinking. The NBMEs, Comprehensive Basic Science Self-Assessment, and the Comprehensive Basic Science exam given by the school, those are predictive. That's the first one. The second one is, how long should I study? Meaning number of weeks, because students are concerned about burnout. It is typically 6 to 8 weeks. Most scholars can do it in about 6 weeks. And that's why working with your learning specialist at your school or your academic advisor, they have different titles, they can help you look at your specific learning plan for those 6 weeks, and you can be effective balancing your wellness. That would be question 2. Question 3, a very important one. What if I'm not doing well on those NBMEs? I'm not on track, right? I'm halfway through. Now I'm in week 4 of my plan. I do that first practice NBME and I score 40%. What should I do? A nuanced conversation. We have to connect now with your academic advisor or learning specialist at your school, because we have to look at very specifically what's happening in your study plan, and maybe also do some one-on-one coaching with your thinking and testing skills for the actual practice questions. And so I know you're also going to make this available. Those are 3 of the 5 questions. We'll look at question 4 and question 5 in a moment. But you probably want to say a little bit about the AME resources that may help in this area.
As we always do, each episode comes with a resource. So on our AME website, you can download our Step 1 resource guide, and that will give you some information about how to navigate talking and, discussing some things with your academic advisor. What resources are best suited for you, discussions about how you are as a learner, and just really getting into the weeds of things before you go into your dedicated period to set you up for the best success.
Excellent. So let's get back to the final 2 questions. Question number 4 is, are there external coaching services that I can use to help me with my thinking and testing skills? Now, we have to be very careful here. That is another nuanced discussion, because all the coaching sessions, or coaching companies rather, are not equal in their abilities to help you navigate what is it that you do well in terms of your test question approach. And so again, we want to consult your learning specialist to help guide you to what are some of the professional coaching services if they're not available at your school. Now, what do we mean by coaching? Coaching is different than tutoring, by the way. Tutoring is, I will help you understand a particular concept that you need to use to think through the problem. Coaching looks at how well do you use your knowledge as well as your thinking and testing strategy to ultimately come to the correct option, or efficiently eliminate options that you shouldn't be considering.
You want to know why I'm smiling? Because until you just said this, I didn't think about that difference. And it makes sense because, as my mentor, you've always been in the background of, academic coaching, right? As the Dean of Student Learning at Georgetown School of Medicine while I was there, you helped me a lot with academic coaching. I had a tutor, though, for Step 1, and he was awesome, right? And so I got him again for Step 2, right? And I would say maybe not deep into our sessions, he said, bro, I don't really feel comfortable taking money from you anymore, because I don't think that what I am doing for you, which is the tutoring, is not necessarily what you need. Now, I was getting both. I was, getting the tutoring, and then also, but we're going over concepts, and that was the concepts. And, mind you, I'm not tooting my horn. You can always improve. You can always improve on your conceptual understanding of the material. But that was not my main issue with the challenges that I faced when preparing for, my STEP exams. So, it's funny that you made that distinction, and I'm glad that you did that. And I'm glad that the students are able to hear that, because I remember he said, you don't need, I won't work with you anymore, for, like the next exam, because there's nothing else for me to go over with this. Like, this stuff. You have the system that I even said with how to go back into, first aid and how to, look at those different sections in a very regimented way for the information acquisition. And then there were some tactics that, he gave about, with approaching, each STEP exam question. But that was mainly how you advised me. That was the coaching, different aspects, understanding the error analysis process. Did I get this question wrong because of content versus a thinking error versus a, testing error? So all of those things that I did not pay attention to, first time around was there in the background. So when I'm checking in with you, you're like, it's not the content that you just explained everything there. So what is the other reason? And I never had that in-depth learning or in-depth perspective of my acquisition of information. So very important point. There's a difference between coaching and tutoring. And, you may not need a tutor. You may need a coach, or you may need both. And so that does segue us into, this bonus segment that we have.
Right. Before we get to the bonus segment, we got one other question that they're waiting for.
Yeah.
And this is also a big one. Should I move my test date?
Oh, that's like one of the...
Should I move my
one of
test
the
date?
biggest ones.
Right? Should I move my test date? And that discussion is never taken lightly because the school may have requirements when the scholar takes the exam for
Right.
step one. It can impact your graduation timeline. It can impact financial aid eligibility. So again, that discussion involves both your learning specialist at your school, but also likely your student affairs dean, who has responsibility for timely progression of students, or it could be the medical education dean as well. But one of those two deans, along with your learning specialist, will help you make that decision, and they'll be evaluating how you've been performing, what else may be needed, tutor versus a coach. And just as a little qualifier, the best coach also can provide what we call targeted knowledge enrichment and understanding. So a coach not only gives you thinking and testing strategy, but can also give you what a tutor provides, which is targeted knowledge or understanding enrichment. But a tutor cannot necessarily be a coach. It's an advanced skill set because you're evaluating multiple competencies. But enough on that. So changing the test date should always be in consultation. Medical student scholars always do that in consultation with your learning specialist and your student affairs dean or medical education dean. Please do not just do that by yourself, and then there are other challenges when you have not consulted them.
So this kind of feels like, FS back in the day.
Yes.
In that basement LA suite of, Georgetown School of Medicine, because we've learned a lot of information today. However, we're not done yet.
We're not done.
We're not
That's
done
right.
yet.
It doesn't end, does it?
No, because back to the board, code 97.
That's right.
So, of course, we're wrapping up the episode, but, we know why you're here.
We know why the scholars are here.
You want the questions.
They want the step one practice questions.
Yes. So we're going to do a bonus segment where we're going to jump into some general questions that we can give our scholars some basic, principles of approaching, these USMLE Step 1 questions, and then have, you kind of break these tactics down. Now, we do understand that, approaching questions in study techniques or, testing techniques is also an additional nuanced, conversation.
Yes.
It is a nuanced conversation. So being that we don't know all of our scholars watching, we want to give some general tips about how to approach step one questions, and then we'll take it from there.
Excellent.
You ready to jump in?
Yes. And let's preface our conversation with, again, we have a few sample questions that we've curated from actual NBME assessments that are publicly available. And some of the NBME practice questions have very short vignettes, only a few sentences. And you'll see those on the actual step one exam. However, the majority of questions have medium to long vignettes. And we need to recognize that because that'll be a competency in terms of both thinking strategy, what is actually important for me to extract and use to problem solve, and testing strategy. What are my steps to actually engage that process, right? And so we do that, of course, in some of our larger webinars or in-person workshops or individual one-to-one coaching sessions where we can go through those more extended vignettes. So I just want to put that qualifier there. Now,
and then also more tailored to with the learner.
Exactly. Yeah. Now, for all scholars, I want you to consider the following mantra when approaching step one questions and in future step two and even step two CK. Any of your medical school exam questions as well. And that is, always focus on first, what information do you know and understand? And you're going to use that information along with your excellent thinking and testing strategy to either impeach an option, not consider it, immediately exclude it, or consider an option for possible final best answer. Now, the reason why I always say, let's start with focusing on what you do know, because as you know from experience, scholars can read one or two sentences and say, oh, I don't remember that. Oh, I'm in trouble. I don't remember that. And as we said in a previous facilitated session, the mental saboteur loves when you say that. Right?
But you're saying, basically, you're going to use what you got to get what you want.
Exactly.
And that's a passing score.
I love it. Use what you got to get what you want, right? To get the passing score. And that's why in this process of focusing on what you do know, along with thinking and testing strategy, you may find in some instances, you may not need a lot of information. A lot of times we think we need more than we do. So we're going to figure that out today when we approach the questions. So sometimes I'll also say the least amount of information that you know, along with thinking and testing to impeach or select an option. All right, let's get into it, shall we?
Shall we?
All right, let's go to question one. Of course, being the outstanding physician and having gone through this process with me, you know I got to put you back in the hot seat.
Oh, that's cool.
You know, so you're representing all the medical student scholars during this question, right?
Okay.
All right.
So
let's proceed with this question, the first question.
All right. A 14-year-old girl presents with a 3-month history of red bumps on her skin.
Let's stop right there. You know how I love to do that, right? You have always emphasized that epidemiology, sometimes the age or the gender could be helpful.
Demographics.
Right? Demographics. And so here you have a 14-year-old and we're hearing about bumps on the skin. Now, we all know in our youth, we're all concerned about acne or something else. There's some derm issue, right? Dermatological issue. So we don't know if this is acne, but whatever it is, it's been going on for 3 months.
Right.
All right, let's keep that in mind. Let's keep going.
The bumps are not itchy or painful, but she finds them embarrassing.
Let's stop right there again. So one of the techniques is if you can stop briefly after each sentence and just quickly process it, that could be helpful to you. So it's not itchy and it's not painful. So whatever it is, it shouldn't be itchy and it shouldn't be painful. All right? But whatever it is, it's embarrassing. So it's kind of sounding like it's something, maybe acne because of the embarrassing piece, but we don't know. But we know it's not itchy and it's not painful. Okay, let's continue.
She has no significant medical history and takes no medications.
What does that mean?
Basically, this is not a, sequelae of something that she had pre-existing already. That would already be in the EMR. So we don't have anything to go off of from her history.
All right.
Is giving us information for this presenting issue. The last thing is vital signs are within normal limits.
All right. What's our question?
Which is the most likely diagnosis?
So this first must be what we call the baby diagnosis, relatively speaking, for step one, because most of the questions are not diagnosis questions. They are, here's the condition. Either they tell us that or you have to figure out what it is, and they say what went wrong.
Right.
But here we're asking what is a possible diagnosis. Okay, let's go through the options.
A, eczema.
When you think about eczema, what's the first thing that comes to mind?
Something that's been chronic.
Okay, something's been chronic.
And itchy.
Itchy.
Yes.
Uh-oh, can we impeach this option?
Yeah.
Why?
Because it said no itch.
No itch.
No pain.
Least amount of information. No itch, you're itchy. Everyone has an eczema. Brother eczema, he's scratching, out.
Right.
See that? We can immediately impeach it. Okay, so I'm going to go ahead and impeach that.
All right.
Boom. All right, let's go to the next option.
B, folliculitis.
I don't even know what that is, but I do know what itis means. What does itis mean?
Inflammation.
Suffix, inflammation. Inflammation tends to be what?
Red.
Red?
Warm.
Is it comfortable?
Painful.
Painful. Oh, but this said no
pain.
No pain. We can impeach it. Least amount of information. I don't know what folliculitis is, but I know what itis is. Look at that. Least amount of information. Let's go to C.
Hydronitis.
Stop right there. I don't even know what hydronitis. What is that? Is that a plant? But I know what itis means. Now, not itis in some of our cultures, which relates to I'm full. It's a different
full
story.
and I'm sleepy.
But that's right. But this itis in medicine right here usually means, again, inflammation.
Right.
Inflammation typically is painful. This said no pain, right?
Right.
So that little piece in the vignette, not itchy or painful, that was key, wasn't it? Because we've just impeached 3 options based on itchiness or pain. Okay, let's go to D.
D, keratosis pilaris.
I don't even know what that is. If we don't know what something is, we should initially skip it. We don't know whether we can exclude it yet, but we should skip it and see what we can do with any of the other options. All right, let's go to E.
Urticaria.
That sounds familiar. What is that?
Bumps, pustules. Papules.
Papules. Oh, papules, pustules.
But okay.
That doesn't sound good.
No. It's because we're going about least information. So I know with urticaria, that's typically some type of, reaction, some type of
reaction.
Yeah, some type
like
of
an allergic reaction.
An allergic reaction.
If it's an allergic reaction, what would you typically have anytime people say they have an allergy to something?
What would you typically have? An allergic reaction.
It was an allergic reaction, but what symptoms? Rashes. Okay. Is it going to be itchy?
Yeah. It can be painful, it can be warm.
It could be pitchy. Okay. So I can take itch, I could take pain, whatever it is, I can eliminate it based on that then. So if I say allergy, I'm typically going to be squirming, itchy, could be sneezing, whatever it is, but that's a potential way to eliminate that. Well, wait a minute. I just eliminated 4 of the 5 options just based on itchy or pain. I don't know what D is. Here's where testing strategy comes in. If I am confident that the other 4 options are absolutely incorrect, they either relate to itch or pain. Are you confident of that?
Yeah, they are not related to itch
then
or pain.
D has to be the answer. It has to be the answer based on testing strategy. And some scholars, though, make this mistake.
Still won't choose it.
I don't know what D is, and because I don't know what it is,
I'm going to choose it.
I can't choose it. No, they say I can't choose it. So they start looking at the other options they eliminate and say, well, maybe eczema is not, maybe it's not itchy, but I have a bad feeling. I'm going to choose eczema even though I don't think it's the answer. That doesn't make sense. I'm going to choose something even though I don't think it's the answer. This is why it's so important to be confident in the testing strategy. If I used the least amount of information, is it itchy or painful? And I did that, and I impeached those options based on that. My thinking tells me there's nothing else here, so testing strategy says that has to be the answer.
Right.
Now watch this. I'm going to ask you your confidence level on a scale of 1 to 10. 10 being you've been a practicing physician for 100 years. That's how confident you are. 1 is you still in elementary school saying you want to be a doctor. What's your confidence?
That the answer is D?
Yes.
100%.
100%?
Yeah.
Why are you so confident?
Well, I look at the things that we just went through. So we defined in the vignette, no pain, no itch. There's no significant medical history. For me, when I think about eczema, typically that's something that's going to present in youth, right? And so 14 years old, maybe she could be getting it around that time. But I'm confident enough that with it not being an itchy or painful, presentation, with it not having any medical history to explain where he's coming from, I can take out eczema. I could take out folliculitis and hidradenitis based off of the fact of no itch or pain and knowing what these things are. Urticaria, like we said, it's an allergic reaction that typically gives you these, itchy wheals.
Okay.
And
All
so
right.
with that being said, keratosis pilaris, even without knowing what D is, that would be the answer. And I'm 100% confident.
Okay. Well, it looks like you are correct because once we pop over to our next slide to clearing this all up, well, look at that. When I scroll down here, what do I see? Keratosis pilaris. And now we see what that actually is, but guess what? We didn't have to know that.
Right.
because we focused on what we did know,
Right.
along with thinking and testing strategy. Because sometimes in the actual exam, we're not going to know everything.
Yeah.
Isn't that interesting? Okay. Let's go to our next question and see what's going on there.
All right, I'm just keeping score. I'm one for one.
Yeah, you're one for one so far.
Okay,
That's right.
1 for 1. All right.
I like
So
that.
question 2. A 50-year-old male, severe obesity and obstructive sleep apnea with increasing daytime somnolence. I'm thinking that this vignette is going in some type of respiratory context, some type of metabolic context, because we're talking about obesity, which could include anything from, we can talk about metabolic issues such as diabetes, high cholesterol, blood pressure, which can have a litany of different things that can happen because of it. And then also when you're talking about this obstructive process, we're talking about the balance between CO2 and O2 and the different effects that those CO2 and O2 can have.
All
with
right.
you. Yeah.
So all this happens in your brain within like 15 seconds or so. We're just slowing it down.
Yeah.
All right. Okay. So let's keep going.
So arterial blood gas on room air shows a pH of 7.31, PCO2 of 70, and a PO2 of 50.
Look at that. What are you going to do with that? That's the ABG there.
Yes.
So you got your patient acidotic.
Yeah.
You got
so,
CO2 retainer. That's not surprising because of the obstruction, right? Okay, and then that arterial oxygen is pretty low. Let's say
I just remember back, sometimes when you say certain things, it brings me back in time. And I remember acidotic versus acidemia,
That's right.
these very granular, different, interpretations of a word
That's
that
right.
sounds similar, but depending on
Language.
what
That's
it
right.
is can be different.
That's correct.
So what we're looking at here, like you said, is an ABG, and we're seeing that our patient is acidotic, but the goal is to figure out whether or not this is a respiratory and metabolic acidosis.
Right.
And that's typically the thing. So when we go at our PCO2, we see 70 milligrams of mercury, and then our PO2 is 50. So both of those figures are abnormal. The PCO2 is significantly higher than what it typically be on a normal patient, and the PO2 of 50 is significantly lower than what we would want it to be.
So now we got to figure out if this hypoxia or hypoxemia. That could be another academic PTSD.
Hypoxia.
But that's right. But with that noted, there is going to be now a sort of pathophysiology that you're describing here to me, because this question says, with that ABG, which of the following additional findings is most likely? So we're going to be focusing now on the impact of this presentation. It's going to be pathophysiology. So let's see where it goes. Read option A for me. Tell me what you're going to do with it.
So option A, decreased serum bicarbonate concentration. So I'm going to impeach A.
That's funny because I had already impeached it myself. Why are you impeaching it?
Because it should be increased. That would be the proper compensatory mechanism, because our patient has acidotic. He's acidotic.
Okay, they have a respiratory acidosis, so you're going to have a metabolic compensation.
Yes.
Okay, that was good. Let's go to B.
B, increased hemoglobin concentration. So when you talk about B, this is a possible, like just going off of GP, I haven't given myself the seconds to think about it, but B, when you're looking at erythropoietin production, typically happens when you have, increased CO2 levels. And so that is letting the body know that there's some type of acidosis going on, and then your body increases erythropoietin, so this way you can hold on to oxygen a lot more. Yeah.
So is it that, okay, I may buy some of that because, as a facilitator, I have fun with you. So yes, there is an increased CO2 because there's an obstruction, so they're acidotic. But as a possible consequence here also, because of this obstruction, the oxygen is lower, so there's a perception that you either have hypoxia or hypoxemia, right? So as a compensatory response, you're thinking, if I increase the carrying capacity,
Right.
erythropoietin, increase in red blood cells, a polycythemic response, so that could be increased carrying capacity. If more oxygen is available, then I can load up the red blood cells. But now we may find later, because there's an obstruction, we may or may not be able to do that. Nevertheless, that could be a compensatory response. You're saying that would make sense.
That would make sense. And the more, since you flushed it out, I'm more confident about it. But in terms of a quick, let's, impeach or go through.
Or hold on to it.
Yeah,
yes.
or hold on to it. I didn't do that much processing yet.
That's
but
a very good point. Again, we said at the top, least amount of information with thinking and testing to either immediately impeach or consider.
Right.
So you said, I have enough to consider, and you stopped and you're ready for the next option.
Right.
So that's testing strategy efficiency. Oh.
Yeah.
I see. Let's proceed to option C.
Okay, option C, increased total lung capacity. That would be wrong because, again, the compensatory mechanism, at least from the respiratory standpoint, when you have an obstructive process, you're going to have decreased total lung capacity.
Oh, yeah. Okay. So that means
because
that
air is being trapped, so you have decreased total lung capacity.
Oh, okay.
Yeah.
What about D?
Well, D is left ventricular hypertrophy. So LV hypertrophy. Now, see, so on the quick, glance, I would consider this and then just review back A, B, C, D, figure out that I impeached A, figure out that B is a possible, C was impeached. So now it gives me the time to go. If I had more options, I would just leave it at that, because when I'm thinking high CO2, I'm thinking about, the metabolic issues with the severe obesity and possible high blood pressure, different things, the hypertension that could come with that. There can be a compensatory left ventricular hypertrophy. That's not necessarily the framing totally of this vignette.
Interesting, because you were not given the blood pressure.
Not given blood pressure.
So this is a good example of how now the National Board of Medical Examiners is assessing your ability to focus on the key information, because they're freezing it as a moment in time.
Right.
If you were given blood pressure and some other indicators that now might suggest there is long-standing hypertension along with the sleep apnea, we have to make a decision as to which one of these would be the single best answer. But because no blood pressure is given, we cannot necessarily say specifically that there will be left ventricular hypertrophy. Right? Now, the other context is, if we move it a step further, when there's a respiratory condition, it is likely, with no blood pressure being given here, remember there's no blood pressure given, that with the respiratory condition, it could impact eventually what happens on the right side of the heart.
Right.
So we'd be looking for right ventricular hypertrophy. So that's another nuance here. But again, it's least amount of information with thinking and testing.
Right.
I don't have a blood pressure, so between B and D, B is a more likely option. We would impeach D because I don't have a blood pressure.
Right.
What do you think? What's your confidence level on that?
Confidence is about 100%.
100%. You're pretty
100%.
confident today.
Yeah.
And this FS, you're really focused.
Yeah, because the question, the vignette is clearly, well, I'm not going to say clearly, but for me, it clearly reads that it wants us to look at some type of, compensatory mechanism from the information that we're given. We're given an ABG, right? And we're talking about a person who has severe obesity and obstructive sleep apnea experiencing daytime somnolence. They gave us the ABGs, which had CO2 and O2 at abnormal levels, and we see that the pH is 7.31, which is an acidotic, situation. With that being said, left ventricular hypertrophy, it could be an option just based off of some of the other descriptors of the patient. However, that's not what's necessarily being asked. So if we're, charge of students to answer the best,
single best answer based on information that's available.
Right, based on the information that's available, it would be B because that happens.
Okay, you made your case. Let's
go take a look. I'm in the courtroom.
Let's go take a look and see if you're correct. Well, you're correct again. For the reasons that we already stated, chronic hypoxemia, low O2 content in the blood, right, is going to lead to a compensatory polycythemia based on increased release of erythropoietin. Okay.
And I actually forgot about the term polycythemia. I mean, I know what it is, but
Yes.
off of the rip with seeing, this is step one, so I haven't seen step one in a while, but seeing this, and we always, repeating this information, but I did not remember, like, okay, the second polycythemia. But again, going back to answering with the least amount of information, just understanding the physiology of how the body works allowed me to be confident enough to pick B.
Right. And the other piece I always remind the scholars of is that in the assessment, we're navigating with key strategies, which is core knowledge that we do know with thinking and testing strategy. However, once we are on the clinical rotations on the wards, it's incumbent upon me to say, oh, yes, this would be a polycythemic response. I need to be able to explain that to my resident or my attending because now I'm engaging patient care. So yes, for the exam, that's fine as a strategy because whether you give the core information you did or all the information I gave, we both are only going to get 1 point.
Right.
We're only going to get 1 point for the question. So being efficient and correct is the best option. Now, as we move and now we're working with patients, we both want to be able to present the full picture, and that's part of our continuing professional responsibility, right? So based on context is what we do. Let's take a look at question number 3 and see if we can have you go 3 for 3.
All right. I'm feeling pretty good here. Let's jump in. So a 51-year-old man with long-standing gastroesophageal reflux disease, GERD, and suspected Barrett's esophagus reports worsening symptoms during the holidays despite maximal omeprazole therapy. What is the most appropriate initial action?
So again, we have very short vignettes for the purposes of this FS. And in this case, a classic GI condition, right? GERD or gastroesophageal reflux disease. And notice in the step 1 question, they may mention the drug, but they're not asking in any of the options per se, what should we do with the drug? Should it be pharmacotherapy? Now remember, we said on step 1, we never ask you pharmacotherapy. It's only mechanism of action, right? I'm going to show you a quick testing strategy. Look at option E. What does it say?
Switch proton pump inhibitors.
Is that a type of pharmacotherapy? Or is that a mechanism of action?
That is a pharmacotherapy.
So I can immediately impeach it because that's not what we do on step 1. Just based on the fact that's a change, that's now, I think we're into our 3rd or 4th year on step 1 where they changed it. There's no pharmacotherapy on step 1. It's all mechanism of action. So we might mention the drug, but eventually it'll be mentioned. If it's not mentioned for the purposes of pharmacokinetics or mechanism of action, you can impeach it.
Okay.
See? So that's a quick one. I'm going to go ahead and impeach it on my screen.
Gotcha.
Now, why don't we run through the options now? I just saw that and peeked at it. That's called being aggressive as a testing strategy. That when we get good at this, our field of vision sees options very quickly. And as soon as I saw that, so I'm going to impeach that.
Impeach it.
Just based on the fact that's a pharmacotherapy.
Right.
All right. So take me through option A.
Ask about dietary and alcohol intake. Well, that's a possible.
Okay.
I would consider that because it's basically telling the it's basically assessing your your lifestyle. And typically when you're having something like this, a GERD and a Barrett's esophagus, worsening symptoms, the vignette is giving a time constraint of during the holidays.
That's all true. I'm gonna bust in on you and say, but that doesn't matter because he's taking the maximum amount of omeprazole. He's taking the maximum amount of his medication. So why would I be caring about his diet?
Well, because it says during the holidays, despite maximal omeprazole therapy. So to me, the vignette is specifying that this is just a holiday thing. And
but isn't it also, irrespective of just being the holiday thing, the first part of any type of gastroesophageal reflux disease is dietary control. We can control it with diet.
Yeah.
Oh.
So that's what I'm
So
saying.
there are two reasons we could look at this then.
So lifestyle, because I guess where I'm getting at,
Yes.
just thinking back on Thanksgiving that just passed and how much I ate, thinking about how much I'm going to eat and drink for, Christmas dinner. That's a lifestyle.
So it's lifestyle is the key component.
Lifestyle.
That epidemiology context again.
That brings in the dietary thing.
Okay.
Because, it's specifying like holidays despite maximal omeprazole. So it seems like it doesn't say that the maximal omeprazole wasn't working for a time. And maybe I can be thinking too deep into this. But
it just said during the holiday period. You said
during
there's a
the
qualifier.
holidays. So
Okay.
it seems
So you
like
wanna keep
something
that one.
changed during the holidays.
Yeah, you ate more and drank more.
Possibly.
Okay, so we're going to hold on to that one?
Well, hold on.
Okay.
B, explain risk of untreated Barrett's esophagus. So, this is all kind of like, patient care, like the different things that you should do. And, I would hold on to that because that also speaks to lifestyle and advising your patient about lifestyle modifications, because at this point when you're explaining the risk of untreated Barrett's esophagus, then we could go into options about how to mitigate the GERD, which could be lifestyle modification.
All right.
Or, some type of, escalated, approach. C, order upper endoscopy. I'm just going to cancel that off top because that seems like very invasive to do at this point. D, refer to a GI doc. I would impeach that because, you have to do, that's the main thing. You have to do as the primary on this patient.
All right.
The necessary workup and, treatment before you're giving that, consult, that referral.
Okay.
So I'm going to take D out.
So C and D are out. So you got two options, A or B.
Yeah.
Is there anything that can help us delineate between the two? Is there a qualifier in the question stem?
Yeah.
What's the qualifier?
The qualifier is the most appropriate
So
initial action.
it's appropriate and also initial.
Right.
There could be an initial action, but it may not be appropriate for you.
Right. I see where
Right?
you're going.
Because sometimes there are things, there could be another condition you have. And so even though I would normally do this first,
Right.
I can't for you because of X, whatever it is.
Right.
So we have to watch these qualifiers in the question stem as a matter of testing strategy, because this one is implying a sequence of possible remedies.
Right. Yeah.
And wants to know what should you do first, and it should be appropriate. So between these two, which one seems to be the initial action you should take? Should you talk about diet and alcohol intake, or should you explain the risk of Barrett's esophagus first?
So the things that jumped out to me was the first letter, the first word in both choices. A is ask and B is explain.
Interesting.
So as the first appropriate initial action, especially if we're going back to the vignette, we're not telling the student to do that, but going back to the information, we're seeing holiday despite maximal omeprazole. So this is indicating that some change happened with this patient during the holiday season. So as the physician getting a proper history and physical, you need to first ask the patient.
So we're going
what
with
might
A.
be the change.
Doesn't that make sense?
100% confident.
Because, it seems like I could do both of those, right? They both could be appropriate, but which one should be done first? I should get information first, right? Because that's going to give me more of background and context of what to do. And you're 100% confident in that.
Right.
That's you. I think you may be 3 for 3 today.
I am 3 for 3.
Wow, look at that.
Sure I'm 3 for 3.
Okay.
I gotta keep the score. I'm on the hot seat. I'm a little nervous.
That's why you're in the hot seat and you got literally hundreds of thousands of viewers.
Just looking at me truck these questions. So
all right.
Let's
go to our final patient day. So we've seen so far across this step 1 context that you could have a basic diagnosis and you didn't need much information except some understanding of pain versus itching.
Right.
Then we saw the next question, a lot on pathophysiology, which is like the anchor of step 1. And then in this past question, we saw a little bit of what we call the epidemiology part of step 1. And knowing, that's right, how to ask appropriate questions, communication skills to gain more information. But again, each of the 3 were wrapped up in a clinical context.
Yeah.
Step 1. Let's look at the last question.
Okay, this is a short one. A 26-year-old man presents with polyuria and polydipsia. Urine osmolality is 50 milliosmoles per kilogram and normalizes after administration of ADH. Which structure is most likely dysfunctional?
Okay, before we get to that structure, what's going on? Because this is a situation again where sometimes on a step 1 exam, they'll give us this little sentence or 2 sentences, and then they'll say the patient was diagnosed with X to help you out.
Right.
Other times they won't say that, but you have to know what the condition is so you can then answer the question, which is saying there's a dysfunctional structure. So this is almost like an anatomy and pathophysiology question wrapped up in one. Isn't that interesting?
It is interesting.
All right. So what do you think is going on with the patient first?
So I'm taking this step by step because when you talk about osmoles and stuff, you know, that saboteur just
academic intimidation. Ooh, I don't remember.
Yeah.
What's going on?
So let's take it step by step. I see polyuria. I see polydipsia.
Yeah. As soon as you've seen those 2,
diabetes.
When you see those 2, you think diabetes. That's right. Okay.
And then, you know, if you look at that second portion of the vignette, it says urine osmolality is 50 microosmoles and normalizes after administration of ADH. So to me, this is some type of hormonal issue that
involving ADH.
Can
we stop there?
Yes, because the question says once you administer, it normalizes.
Okay. So that means whatever this. So is there something with ADH that can lead to diabetes?
Yeah.
Okay. So we could stop right there.
Yeah. Diabetes insipidus.
Oh, well, thank you, doctor.
Right.
I see you got your diagnosis. Oh, look, he's sitting back all confident.
Right.
All right. So the question is saying which structure is dysfunctional? So what structure are we looking for and why? What structure are we looking for?
So diabetes insipidus would be more of, the sequelae, diabetes insipidus would start more in the brain. Or it can be primary or it can be secondary.
Well, without getting to that detail,
okay,
let me ask you this. You said ADH because you got me circling it. Is that the hormone that's the issue?
Man, this question is throwing me.
Ooh. Would you like for me to call one of the medical scholars in the studio audience and ask them? They're already telling me on the screen, they're all saying, yes, it's ADH. You need to look for ADH. So they're saying to me, according to the screen, we should be looking for a structure. I see you smiling because you see all the thumbs up on the screen, a structure related to ADH.
Right.
So this is simply asking us, which of these structures secretes ADH? And it must be dysfunctional. Because when you replaced it with ADH, everything was fine.
Right.
All we got to do is figure out which structure releases ADH. So this is a situation where, you know how we always say we have to know some information? The saboteurs say, see, you don't know it. You got to know those facts. You got to know those facts.
But it's coming back.
Can we impeach it? It's coming back?
It's coming
back.
Well,
let's go through it.
So it says, which structures is most likely dysfunctional? From a preview of this, I see brain structures and I see renal structures.
And you said it could be the brain.
It could be the brain, or it could be, and that's it. There's primary and secondary diabetes, or central versus central diabetes insipidus versus like a renal presentation of diabetes.
Really?
Because you can have the initial insult be because of maybe your mood stabilizer. You know.
Oh, okay. Well, you're getting deep.
Yeah.
Well, I hope that's not all there on step one.
But you know, so if but thinking back to this, I brought that up because that would be the insult, like a secondary, process where the insult would happen at the
But
root.
if we were doing that in the exam, would that be too much thinking? Would that be taking us into a deep dive? Would that be taking us to what we like to call the vortex?
It would.
Oh, were you just illustrating the vortex just to take me down that lane so I could talk about vortex?
I'm trying to buy some more time to figure the answer out.
Like an outstanding student scholar.
Yes.
Well, I'm going to suggest to you that ADH is synthesized in the brain.
Yeah. Well,
right?
That I know. So,
okay. So in that case, should we impeach options that don't relate to the brain?
Yes.
Which ones can we impeach?
B.
Bowman's capsule. That's in the kidney.
C.
Glomerulus. That's the kidney.
And then E. Loop of Henle.
That's in the kidney. Okay. All right.
So
my screen popping up here. Okay, so that leaves us now with anterior pituitary A, hypophyseal portal system D, or supraoptic nucleus F.
Okay.
Remember, you're 3 for 3 so far, so I know you don't want to miss this question.
I'm going to get this 4. So A, anterior pituitary, no. We know, flat peg. That's the mnemonic for all of the hormones.
Okay.
Yeah.
All right, so we're going to impeach A. Okay. You now have a 50% probability of getting this question right.
So the hypophyseal portal system, I don't remember what that is. I don't remember what it produces.
If it produces anything.
If it could just be.
It could be part of a system of a transport process.
Right. Yeah. So
maybe transporting some substances from some aspect of the hypothalamus to the posterior pituitary.
Exactly. But I do
know. I may happen to know that, but as I always say, what do I know?
Right.
I'm just a mere facilitator.
But what I can say, and the reason why I'm going to be 4 for 4 today, is because the supraoptic nucleus are part of the hypothalamus that are, and when you said that, the portal system does do that relay of transport from the hypothalamus.
Ah, okay.
So, but the supraoptic nucleus, I know that is a portion of the hypothalamus that does produce ADH.
Oh, okay. You're confident about that. So you're going with F. And what's your confidence level on that? Because, you were doing what most medical student scholars do. You were jiggling your leg, rubbing your forehead.
I'm nervous, man.
This is real. This is real, right?
It's and they're short questions, but I'm on the spot.
That's a very good point also, is that we never underestimate whether the question is short or long. Long questions sometimes may just be academic intimidation.
Right.
And we'll, when we do some of our webinars where we invite our scholars to join us, right, we can show how we navigate that. But short vignettes can also be challenging because they may have some key concepts that we're familiar with or, maybe not as confident. But right now you're going with F, and what's your confidence level on that?
I'm going to say 100% just because I will say I'm 100%. 100%.
Not 80%, 85%. I always say 75% more confidence, pretty good. I love 90% more confident. But if you struggle with the question and you're 75% confident, it means you've done some good thinking and impeaching options. You've used some testing strategy. And so that would be a very reasonable confidence level.
So the reason why I'm going to lower my confidence level on this one is because although I believe that I remember that the hypophyseal portal system is that transport, I still don't 100% remember what it is, right?
All right. Okay, so that's reasonable.
But because I do know F is a part of the hypothalamus.
That's the other side of it.
That's the other side of it.
What do you know?
Right. I will go with F. So,
all right. Probably 95%
I'll say
confident?
95% confident.
Okay. Well, it looks like, just like on some of those outstanding game shows, I can hear the music being the tension right now.
I'm 4 for 4.
You are Correct.
Yes. I'm improving.
All right. Outstanding
last time
job,
was 3
Dr.
for 4.
Jackson.
Now it's 4 for 4.
That's right. But on a serious note, we wanted just to share with our scholars that step 1 questions can be effectively navigated with a baseline strategy, as you helped us understand earlier, using what you got
to get
what you want, right? Least amount of information with thinking and testing strategy to either exclude an option or optimally select the correct option. And when we do that, we can be successful on our step 1 questions. It sounds like we're ready to wrap up this facilitated session, Dr. Jackson.
So that brings us to the end of episode 1, and stay tuned for episode 2, where we are going to pivot to the clinical ward. So we did speak already in season 3 about what it's like during that clinical ward, experience. But today we're going to do a deeper dive about that clerkship experience. So see you over at episode 2.
See you next FS.